Here's a detailed explanation of platelets, their functions, production, and the blood clotting mechanism, including clotting time, bleeding time, and partial thromboplastin time, PTT. Place. Definition: platelets, thrombocytes, are small, irregular, enucleate cell fragments derived from megakaryocytes in the bone marrow. They circulate in the blood and play a critical role in hemostasis, the cessation of bleeding, primarily by forming clots. Structure and characteristics: size, 2 to 4 micrometers in diameter; shape, disc-shaped when inactive; nucleus, none, enucleate; number in blood, 150,000 to 400,000 platelet; lifespan 7 to 10 days; storage, to 1/3 stored in spleen; rest circulate in blood. Functions of platelets. Function, description, ADP, serotonin, hemostasis, clot formation. Form temporary platelet plugs at injury sites and initiate clotting cascade. Release of clotting factors. Release chemicals like ADP, serotonin, and thromboxane A2. Vessel repair. Secrete platelet-derived growth factor, PDGF, to stimulate tissue healing. Maintain vascular integrity. Prevent spontaneous microvascular leakage by supporting endothelium. Immunological role. Interact with white blood cells involved in inflammation and pathogen defense. Production of platelets, thrombopoiesis. Steps of production. 1. Origin, from hematopoietic stem cells, HSCs, in red bone marrow. 2. Differentiation, HSC myeloid progenitor, megakaryoblast, megakaryocyte. 3. Maturation. Megakaryocytes undergo endomitosis, DNA replication without cell division, to become large multinucleated cells. 4. Platelet release. Cytoplasmic extensions, proplatelets, break into 1,000 to 3,000 platelets per megakaryocyte. Hormonal regulation. Thrombopoietin, TPO, a glycoprotein hormone produced in the liver and kidneys, stimulates megakaryocyte proliferation and platelet production. Blood clotting mechanism, hemostasis. Hemostasis involves 3 main steps. 1. Vascular spasm, vasoconstriction, immediate constriction of damaged blood vessels, reduces blood loss, triggered by endothelin, nerve reflexes, and serotonin released by platelets. 2. Platelet plug formation, primary hemostasis. Platelet adhesion, platelets stick to exposed collagen fibers of injured endothelium via von Willebrand factor, VWF. Platelet activation, platelets release chemicals like ADP, serotonin, thromboxane A2 that attract more platelets. Platelet aggregation, platelets bind to each other via GPI-IB3A receptors, forming a temporary plug. 3. Coagulation cascade, secondary hemostasis, a sequence of enzymatic reactions that convert fibrinogen to fibrin, stabilizing the platelet plug. 3 pathways. Trigger, factors involved. Common factor, intrinsic pathway. Intrinsic pathway, collage, collagen, sign, ING, 8. Extrinsic pathway, external trauma, 3. Tissue factor. Common pathway, convergence of X, V2, prothrombin, I, fibrinogen. Final steps. 1 factor X, XA. 2. XA plus VI convert prothrombin to thrombin. 3. Thrombin converts fibrinogen, I, fibrin. 4. Fibrin strands form a stable clot with the help of factor 3 for stabilizing factor. Clotting time, T. Definition: time taken for a sample of blood to clot outside the body in vitro. Normal value, 5 to 15 minutes, varies based on method. Test, capillary tube or slide method. Bleeding time, BT. Definition: time from puncture to cessation of bleeding, evaluates platelet function. Normal range, 2 to 7 minutes. Duke's method, finger prick or earlobe. Ivy's method, forearm incision under controlled pressure. Increased BT, seen in platelet disorders, thrombocytopenia, or von Willebrand disease. Partial thromboplastin time, PTT-APTT. Definition: measures time to clot via intrinsic and common pathways. Normal range, 25 to 35 seconds. Clinical use: monitor heparin therapy, detect deficiencies in factors 12 by AXV2A, Assess clotting disorders like hemophilia AB, liver disease, or DIC. Quick comparison table: Teger's, normal range, clinical significance, clotting time, overall coagulation defects. Platelet plate function and small vessel integrity, 2 to 7 minutes in platelet disorders or VWD. Clotting time, overall coagulation ability, 5 to 15 minutes, prolonged in coagulation defects. PTT, APTT, intrinsic plus common coagulation pathways, 25 to 35 seconds. Monitors heparin, detects hemophilia DIC. Summary: platelets initiate clotting by forming a temporary plug and activating the coagulation cascade. Thrombopoiesis is regulated by TPO and occurs in the bone marrow. Hemostasis is a three-phase process: vasoconstriction, platelet plug, and coagulation. Laboratory tests like BT, CT, and PTT are essential to assess clotting function and diagnose bleeding disorders. Here's a detailed explanation of hemostasis, covering the role of vasoconstriction, platelet plug formation, coagulation factors, and both the intrinsic and extrinsic pathways of the coagulation cascade. Hemostasis. Overview. Definition: hemostasis is the physiological process by which bleeding is stopped at the site of blood vessel injury. It involves a tightly regulated cascade of events that prevent blood loss, maintain blood in a fluid state within vessels, and dissolve clots after repair. Phases of hemostasis. Hemostasis occurs in three main stages: 1. Vasoconstriction, vascular spasm; 2. Platelet plug formation, primary hemostasis; 3. Coagulation cascade and fibrin clot formation, secondary hemostasis. A fourth phase, fibrinolysis, occurs after vessel healing, dissolving the clot. 1. Vasoconstriction, first line of defense. Role: narrowing of the blood vessel immediately after injury, reduces blood flow and blood loss, provides time for platelet activation and clot formation. Mechanisms: reflex neurogenic response, myogenic spasm of smooth muscle, chemical mediators, endothelin, released by endothelial cells, serotonin and thromboxane A2, released by activated platelets. 2. Platelet plug formation, primary hemostasis. Steps: 1. Platelet adhesion. Platelets bind to exposed collagen at the injury site via von Willebrand factor, VWF. 2. Platelet activation. Shape changes from disc to spiny. Secretes ADP, thromboxane A2, TXA2, and serotonin, which recruit more platelets. 3. Platelet aggregation. Platelets stick to each other via GPI-B3A receptors, forming a temporary platelet plug. This plug is unstable and needs to be reinforced by fibrin from the coagulation cascade. 3. Coagulation cascade, secondary hemostasis. Purpose: convert fibrinogen soluble into fibrin insoluble to stabilize the platelet plug. Coagulation involves a series of inactive clotting factors, zymogens, that are sequentially activated. Coagulation factors: Roman numerals I3, name, I fibrinogen, 2 prothrombin, 3 tissue factor thromboplastin, 4 calcium plus, V labile factor, stable factor, VATE, antihemophilic factor A, Christmas factor B, X Stewart-Power factor, ecplasma thromboplastin antecedent, Twem Hageman factor, 13 fibrin stabilizing factor. Factors Vic and 4 are either obsolete or non-protein. Pathways of coagulation cascade: there are 3 interconnected pathways. Intrinsic pathway, contact activation pathway, triggered by internal trauma or exposed collagen. Slower, but more amplified. Involves factor TWA, itasfate, X. Extrinsic pathway, tissue factor pathway, triggered by external trauma causing tissue damage. Faster response. Involves tissue factor 3, factor 7, common pathway, point where both intrinsic and extrinsic pathways converge. Steps: factor X plus V, prothrombinase complex, prothrombin 2, thrombin 2A. Thrombin converts fibrinogen I, fibrin IA. Fibrin plus factor 3, stable fibrin clot. Summary diagram text format. Intrinsic pathway, SWAN exine IX plus 8X. Extrinsic pathway, 3 tissue factor plus 7X. Common pathway, X plus V Prothrombin, 2A, I-fibrinogen, IA, fibrin, plus 13, stable clot. Quick comparison. Intrinsic versus extrinsic. Feature intrinsic pathway, 2A, trigger, internal vascular damage, external tissue injury, speed, slow or faster. Main factors, cell psi, eing, threat, Sven lab test. APTT, activated partial thromboplastin time, PT proben time, initiation site, blood vessel endothelium, damaged tissue. Lab tests, related to hemostasis, normal range, 2-7 range. PT, extrinsic pathway, 10 to 14 seconds. APTT, intrinsic pathway, 25 to 35 seconds. Platelet function, 2 to 7 minutes. Clotting time, general clotting ability, 5 to 15 minutes. Conclusion, hemostasis is a vital, multi-phase process that includes vasoconstriction, minimizes initial blood loss, platelet plug formation, temporary seal, coagulation, forms a stable fibrin clot. The intrinsic and extrinsic pathways of coagulation ultimately converge at a common pathway, leading to clot stabilization. Here is a detailed explanation of blood groups and types, including the ABO system, Rh factor, compatibility, and their clinical significance. Blood groups and types. Definition. Blood groups are classifications of blood based on the presence or absence of specific antigens on the surface of red blood cells, RBCs, and antibodies in the plasma, and major blood group systems. The two most important systems used in blood typing: 1. ABO blood group system. 2. Rh rhesus factor system. Based on presence or absence of A and B antigens on RBCs. Presence of anti-A and anti-B antibodies in plasma. Types: antigens on RBCs, antibodies in plasma. A, anti-B, B, anti-A, AB, A and B, none, on, anti-A and anti-B. Clinical importance: group universal donor RBCs because it has no AB antigens. Group AB, universal recipient RBCs because it has no antibodies. Note, plasma compatibility is opposite, e.g., AB plasma is universal donor for plasma. Rhesus factor system. Based on presence or absence of Rh antigen, D antigen on RBCs. Rh type, Rh antigen on RBCs. Rh positive, present. Rh negative, absent. Clinical significance: an Rh negative person does not naturally have anti-Rh antibodies, but can develop them after exposure, e.g., during transfusion or pregnancy. Hemolytic disease of the newborn, erythroblastosis fetalis, occurs when an Rh negative mother carries an Rh positive fetus and forms antibodies against fetal RBCs in subsequent pregnancies. Prevention: administer Rho-D immune globulin, RhoGAM, to Rh negative mothers. Blood transfusion compatibility, compatibility chart, ABOS Rh, incompatible donor types, O-, O-, O+, OS, A-, A+, O+, O-, B-, B-, O-, B+, B+, B-, O+, O-, B-, AB, A-, O-, AB+, all types, universal recipient. Always cross-match before transfusion to avoid hemolytic reactions. NASH blood typing procedure. 1. Mix a drop of patient's blood with anti-A, anti-B, and anti-D antibodies. 2. Observe for agglutination clumping. Clumping indicates presence of the corresponding antigen. Key points. Blood groups are genetically inherited. ABO and Rh typing are essential before transfusion or organ transplant. Incompatibility can cause serious transfusion reactions. Summary table: blood group, antigens can donate, can receive from. So before transfusion, AA, anti-B, AAB, AO, B, anti-A, BAB, O. A and B, none. ABA, BB, O, anti-A, anti-B, AB, ABO, O. Here is a detailed explanation of the functions of the reticuloendothelial system, EAS, and its role in immunity. Reticuloendothelial system. Definition: the reticuloendothelial system, also known as the mononuclear phagocyte system, MPS, is a part of the immune system consisting of phagocytic cells, primarily monocytes and macrophages located in bone marrow, spleen, liver, lymph nodes, lungs, brain, microglia. These cells engulf and digest cellular debris, pathogens, and foreign substances. Key components of RA: cell type, location, histios, monocytes, circulating in the blood, macrophages, tissue resident, Kupffer cells, liver, alveolar macrophages, lungs, microglia, central nervous system, histiocytes, connective tissues, splenic macrophages, spleen, white and red pulp. Functions of the reticuloendothelial system, RES. 1. Phagocytosis. Engulf and destroy dead or dying cells, microorganisms, foreign particles, cellular debris, important for clearing old or damaged RBCs, especially by Kupffer cells in the liver and splenic macrophages. 2. Antigen presentation. Macrophages process and present antigens on MHC class II molecules to helper T cells, CD4+, initiating adaptive immunity. 3. Cytokine production. Macrophages release cytokines such as IL-1, TNF-A, IL-6. These promote inflammation, fever, and immune cell recruitment. 4. Hematopoiesis regulation. Macrophages in the bone marrow support stem cell differentiation, removal of defective blood cells. 5. Iron recycling. After RBC breakdown, macrophages recycle iron from hemoglobin, returning it to the bone marrow for new RBC synthesis. 6. Tumor surveillance. Macrophages can destroy tumor cells or present tumor antigens to initiate immune responses. 7. Support for lymphatic organs. Rest cells maintain structure and immune function of lymph nodes, spleen, thymus. Rest and immunity. Role in innate immunity. Acts as the first line of defense by detecting and phagocytosing microbes, producing pro-inflammatory mediators, activating natural killer, NK cells. Role in adaptive immunity. Antigen-presenting cells, APCs, from RES stimulate T cell and B cell responses. Macrophages cooperate with dendritic cells to ensure robust immune memory. Conclusion: the reticuloendothelial system, yes, plays a central role in both innate and adaptive immunity through phagocytosis, antigen presentation, cytokine production, support of hematopoiesis, iron recycling, immune surveillance. It serves as the body's internal defense network, maintaining immune balance and tissue homeostasis. Here is a detailed explanation of the 15 applications of blood physiology in nursing practice. 15 detailed applications of blood physiology in nursing. 1. Blood transfusion safety. Nurses must understand blood group compatibility, ABO and RH systems, to prevent hemolytic transfusion reactions. Knowledge of cross-matching and monitoring for signs of allergic or febrile reactions is essential. 2. Monitoring hemoglobin and hematocrit levels. Hemoglobin reflects the oxygen-carrying capacity of the blood. Nurses assess for anemia, hypoxia, or dehydration and report abnormal values to guide clinical decisions. 3. Recognizing signs of infection. Understanding the role of WBCs helps in early detection of infection. A rise in neutrophils may indicate bacterial infection. Elevated lymphocytes may suggest viral infection. 4. Managing bleeding disorders. Nurses apply knowledge of platelets and coagulation factors when caring for patients with bleeding tendencies, e.g. hemophilia, DIC. Monitoring for petechia, ecchymosis, and prolonged bleeding times is crucial. 5. Anticoagulant therapy monitoring. Understanding PT, INR, and APTT helps nurses assess effectiveness and safety of anticoagulant drugs like warfarin or heparin. Nurses monitor for signs of internal bleeding, e.g. blood in stool or urine. 6. Administering iron and vitamin supplements. Knowing that iron, vitamin B12, and folic acid are essential for RBC production, erythropoiesis, enables nurses to manage anemia treatment effectively. 7. Caring for postoperative patients. Postoperative monitoring includes signs of internal bleeding, hypovolemia, and hypoxia, which are detected through changes in hemoglobin, blood pressure, and heart rate. 8. Interpreting blood test results. Nurses routinely interpret CBC, ESR, and blood chemistry results to assist physicians in diagnosing and managing various conditions, e.g., infection, inflammation, anemia, clotting issues. 9. Fluid and electrolyte management. Understanding blood plasma composition guides the administration of IV fluids, electrolytes, and blood products, ensuring maintenance of homeostasis. Now, 10. Oxygen therapy administration. Blood physiology knowledge helps in evaluating oxygen delivery and need for oxygen therapy. Nurses monitor SpO2 and assess for cyanosis and dyspnea. 11. Detecting shock. Recognizing hypovolemic or septic shock is critical in emergency care. Nurses monitor for tachycardia, hypotension, cold, clammy skin, and decreased urine output as signs of impaired blood perfusion. 12. Educating patients. Nurses educate patients on maintaining healthy blood through diet, e.g., iron-rich foods, hydration, and exercise, especially in cases like anemia or clotting disorders. 13. Monitoring for transfusion reactions. During transfusion, nurses monitor for adverse reactions like fever, chills, chest or back pain, hypotension. Immediate actions are taken to stop transfusion and notify the physician. NAR 14 Infection Control Practices. Nurses use principles of innate and adaptive immunity, WBC function, antibody response, to follow standard precautions, aseptic technique, and immunization protocols. Supporting hemodialysis patients. Nurses caring for patients on dialysis need knowledge of blood filtration, electrolyte balance, and anticoagulation management to ensure safe and effective treatment. Summary. Understanding the physiology of blood is foundational to nearly all aspects of nursing care. From basic assessments to critical interventions, nurses rely on this knowledge to detect abnormalities, prevent complications, deliver patient education, support treatment decisions, respond to emergencies. Thank you. Have a nice day.